will start a webinar. This is the 7th webinar of the ERN GUARD-Heart webinar series, and today we will talk about the clinical context of nuclear protein defects in dilated cardiomyopathies. A special welcome to our moderator of today, Professor Agostini, but also to the speakers, Dr. Giuliano and Dr. Di Toro, all from Italy. And this webinar will talk about thematic area 5. So Professor Agostini, I would like to give the word to you. You can start sharing your screen now.
Hello everybody, and thank you for this opportunity to share with you difficult experience, clinical experience with genetic cardiomyopathies in our centers. In particular, the title that has been assigned to me, the clinical context of nuclear protein defects in dilated cardiomyopathy. I would give you an alternative title, otherwise said, when at the end of a clinical and genetic path, there are more questions than answers. So this is our, and in particular, I guess we need to very briefly focus on protein expression in myocardial cells and intracellular localization of the protein expression. And I will show you 3 slides. Don't spend time. Just look at the list of genes that are in this column, and you will see that the red filled boxes are those genes that are validated for cardiomyopathies. And in the blue squared boxes here, you see the nuclear expression of the proteins that are encoded by these genes. You can see there's no red filled box here. So go to the next one, but we start seeing here, and we first see one of the proteins that are typically expressed at the nuclear level, which is hemerin, and the second protein which is typically expressed at the nuclear level, which is lamin. And let's see the last one, and we'll find RBM20, which is a protein typically expressed again at the nuclear level in the myocardium. And here you see the examples of what we see with pathology and immunohistochemistry. Lamin, obviously, lamin IC is the most important one. Up to 6% of consecutive dilated cardiomyopathy are associated with the effect of this gene. And here is the typical expression of normal lamin. Here you see the red expression of the protein inflorescence. Hemerin, but hemerin is a protein associated with X-linked Emery-Dreifuss muscle dystrophy, but has a very low prevalence in patients with presenting with cardiac phenotypes. And these patients are usually Emery-Dreifuss patients, and they may also show dilated cardiomyopathy with atrioventricular conduction defect. And here you see the typical nuclear expression of the protein. And the same is true for RBM20, which is RNA binding motif protein 20 gene, which is associated with dilated cardiomyopathy and is typically, again, expressed at the nuclear level. So we have 3 important proteins, but one is very common, lamin IC. The other one is far less common. And lamin definitely is the most important for in our clinical practice, because laminopathies are a group of cardioneuromuscular and systemic diseases that are caused by defect in these genes, and the phenotype, however, are heterogeneous. And I would like to tribute to the merit of having discovered this gene to my friend Kitty Schwartz, who first demonstrated the association with of lamin AC with Emery-Dreifuss muscle dystrophy. And immediately after that, the team of Christine Seidman that first demonstrated the association of mutation in these genes with dilated cardiomyopathy and conduction disease. I guess we don't need to spend time. I know that we had another webinar on cardiolaminopathies, but typical phenotype is dilated cardiomyopathy and conduction disease. Less commonly an arrhythmogenic phenotype or arrhythmogenic dilated and cardiomuscular phenotype. The problem today with this gene and with many other genes associated with cardiomyopathy is the ongoing effort in many centers of Europe and everywhere there are centers that care for or that work on the cardiogenetics in cardiomyopathies, is the reclassification of variants of all genes, and in particular, we are doing a big effort addressing variants using the SCMG criteria guidelines published in 2015, and especially highlighting the role of the clinical criteria that you see here in this red square that can substantially modify the criteria that are automatically calculated by software and by tools that are available for the evaluation of the pathogenicity of these variants. So in the context of reclassification of these variants, we are considering today's question. How do we deal with variants in laminacy when these variants co-occur with other variants in other genes validated for cardiomyopathy? And we are going now to address this question and going with a presentation of two complex cases. We would like to have your opinion. So, Alessandro.
So, good morning, everyone. Thank you very much for this opportunity. Here we have our family tree, and here is our proband. She carries a pathogenic variant in NYBPC3 gene and a VUS in lamin. Of notice in this family tree, the sudden death of the paternal uncle at the age of 74, and also the hypertrophic phenotype of the other family member who carries the MYBPC3 gene. So our proband was diagnosed with hypertrophic cardiomyopathy at the age of 27, and after her phenotype is characterized by non-sustained ventricular tachycardia since the age of 42, in the next years, in the next 10 years of follow-up, she continued to show an arrhythmic phenotype with symptomatic ventricular arrhythmias that led in the end to the ICD implantation of our proband at the age of 53. She did not show any hypercyclemia, and she did not perform competitive sports.
Yes. Okay. From the echocardiographic point of view, we can observe a preserved ejection fraction from the pro-chamber apical view and a severe atrial dilation with asymmetric left ventricular hypertrophy with the maximum wall thickness of 26 millimeters at the interventricular anterior septum and the anterior wall, with a posterior wall of 11 millimeters. The first degree diastolic dysfunction and absence of LVOT obstruction.
The VUS in lamin was inherited by our proband from her mother. Her mother did not have any cardiac abnormality since the age of 77 when she presented with coronary artery disease and did not have any history of arrhythmias. Her sister, the sister of our proband, carries the pathogenic variant in NYBPC3 and shows an hypertrophic phenotype in absence of arrhythmias, and a CMR performed at the age of 42 did not show any late gadolinium enhancement. Here is her echocardiographic.
Yeah. Her imaging shows an asymmetrical left ventricular hypertrophy with a basal lateral wall thickness of 70 millimeters and absence of late gadolinium enhancement. From the echo, we can observe just mild mitral regurgitation, a second degree diastolic dysfunction, and a severe left atrial dilation.
Our proband inherited the MYBPC3 variants from her father, who was diagnosed with hypertrophic cardiomyopathy at the age of 58, and his CMR at the age of 73 showed an extensive late gadolinium enhancement, and this was his phenotype echocardiographically and by the CMR.
Yes, by the CMR, we can observe an asymmetrical left ventricular hypertrophy at the anterior medium basal wall thickness up to 20 millimeters, and extensive late gadolinium enhancement at the hypertrophic portion. From the echo, we can observe the normal left ventricular function, severe left atrial dilation, and first-degree diastolic dysfunction.
So here is a slide to compare our proband, the phenotype of our proband in the center of the slide, with her sister, who carries as well the MYBPC3 variant, but does not carry the lamin, the VUS in lamin, and did not show at the same age any late gadolinium enhancement. Her father showed an extensive late gadolinium enhancement, but more or less 3 decades after his daughter. So they differed mostly for the presence of late gadolinium enhancement, but also for arrhythmias that were recorded since the age of 42 in our proband. Here is one of the first non-sustained ventricular tachycardia that were recorded. Here is the son of our proband who carries the MYBPC3 variants and shows an early phenotype with slightly increased EKG voltage and an echo.
Yeah, from the echo we can observe, just a moment, okay. A preserved ejection fraction, normal left ventricle dimension, upper limit left ventricular wall thickness up to 10 to 11 millimeters, prominent papillary muscles, and just mild left atrial dilation with normal left ventricular diastolic function.
The other son of our proband carries the VUS in lamin and does not show any typical trait of cardiomyopathy, nor any arrhythmias at the age of 20.
Yeah, from the echo, we can observe just a normal left ventricular ejection fraction, a mild left atrial dilation because of a mild to moderate mitral regurgitation, normal left ventricular wall thickness, and normal diastolic function.
So these clinical cases raises questions, and there are so more questions than answers. There is an irrefutable pathogenic role of the MYBPC3 variant, but there is also a debatable role of the lamin variant, particularly when it is considered together with the MYBPC3 variant. Could it have led to the final phenotype of our proband, which is characterized by an earlier fibrosis than his father, and also respectively to her sister, and at the same time, so could have the lamin have contributed to the final phenotype of our proband, which is characterized by a more pronounced arrhythmic diathesis. So there could have been a synergistic effect. Here is the second family that we would like to present to you. Here is our proband. Is a male who carries a non-pathogenic variant in MYH7 gene and a VUS in lamin gene. Of notice in this family tree, the parental consanguinity of the parents of our proband. His father who died in a car crash at the age of 37, and the other two, his sister and his brother, who carries respectively both the variants described in our province and only the VUS in lamin for his brother. He was diagnosed with hypertrophic cardiomyopathy at the age of 20, at 20 years of age, and was first evaluated at our center at 36 years. He presented with a non-obstructive hypertrophic cardiomyopathy with a dilative and dysfunctional evolution and a first-degree atrioventricular block at the basal AKG and hyperCKemia. His following clinical history is characterized by supraventricular, but mostly ventricular arrhythmias that led to repeated cardiac arrest and to the need of a sympathectomy at the age of 47 after a syncope and a ventricular arrhythmia that was treated with a DC shock. So here is here is shown is basal AKG before ICD implantation. You can notice the first-degree atrioventricular block and the complete left bundle branch block.
Yeah, from the echo we can observe just mild left ventricular dilation and dysfunction with ejection fraction about 48%, and asymmetrical left ventricular hypertrophy with maximum wall thickness of 22 millimeters at the interventricular septum, and the severe atriomegalia, absence of LVOT gradient.
So his mother carried the same variants and was diagnosed with hypertrophic cardiomyopathy at the age of 45. She underwent repeatedly cardiac surgery for valvular disease, and at the age of 60, she underwent also myectomy, and in the end, she ended in a heart failure and was listed for transplantation after the age of 62. But after repeated surgery on valve because of the valvular heart disease. His sister carries the same variant as well as the proband. So she was first evaluated at the age of 41, but she did not show the same phenotype at all. She had only a mild hypertrophy of the left ventricular walls, and she had preserved ejection fraction and repeated controls. She had no hyperCKemia, and an history of arrhythmia was completely absent at the ECG Holter monitoring.
Yeah. From the echocardiographic point of view, we can observe just a normal left ventricular dimension and function with just mild left ventricular hypertrophy, 12 to 30 millimeters at the posterior interventricular septum, and just mild left atrium dilation with first degree left diastolic dysfunction.
The brother of our proband was first evaluated at our center at the age of 43. He carries the lamin, the VUS in lamin only, and he did not show any arrhythmia. He only complained of myopathy with an hyperCKemia that had their onset at the age of 54, after a long personal history of heavy physical activity. The CMR that was performed at the age of 55 did show normal cardiac characteristics, and there were no arrhythmias at this monitoring.
Okay, from the echocardiographic point of view, we can observe normal left ventricle dimension function and wall thickness, normal left atrial dimension, and normal left ventricular filling pattern.
So here we have again a comparison slide which compares in the center the phenotype of our proband characterized by severe arrhythmic diathesis, while in her sister, even if she carries the same variant, we do not have the same hypertrophic, the same severe hypertrophic phenotype, and at the same time we did not have any arrhythmia nor elevation in CK. From a cardiac, the cardiac point of view and the cardiac findings in the other brother who carries only the LMNA variants, we have normal cardiac findings. We do not have arrhythmias, but we have, after the age of 54, the onset of myopathy with hyperCKemia. Here is the first of the homozygous twins that are the son of our proband. They both carry both the variants, MYH7 and the LMNA. At the age of 12, currently, this son has normal ventricular dimension, and the cardiac findings are normal except for a ventricular crypt that is described here.
Okay, as you can see in the short axis, there is a left ventricular crypt at the anterior septal basal wall, with thinning of the wall up to 3 to 4 millimeters. But the remain findings are normal, especially normal left ventricular dimension and function and wall thickness.
These homozygous twins, who carries as well, obviously, the two variants, shows an early phenotype of hypertrophic cardiomyopathy.
Yes. Okay. Yes, in the echo we can observe just a mild hypertrophy up to 11 to 12 millimeters on the interventricular septum. We preserve the ejection fraction and normal left ventricle dimension, but with a left atrial enlargement, normal normal ventricular filling pattern, but mild LVOT obstruction.
We have also evaluated the nephew and the niece of our probands, respectively, the son and the daughter of his sister. They both does not show cardiac abnormalities except for an interventricular septal defect that was diagnosed at birth in the proband's nephew. And again, the proband's niece, who carries only the VUS in LMNA, that has normal cardiac findings. Here, a comparison slide in which you can observe the phenotype on the right side of the slide, the phenotype in the two homozygous twins that are different, one between each other, and on the left side, the normal cardiac findings in those who carries respectively the MYH7 variant, but at the age of 11 years old, and the LMNA VUS respectively. So from these cases raises more questions than answers, exactly as the cases before, because beside the irrefutable pathogenicity of the variants in variant in MYH7, there could be a debatable role of the LMNA variant that could currently be interpreted as a hot VUS. We wonder if the longitudinal monitoring of the subject 6.1 and the subject 6.2 could add information, and how should we interpret the phenotype mismatch that exists between our proband and his sister. Should we expand the multi-gene panel test to a whole exon sequencing, particularly in our proband? And also in this family tree, there was consanguinity. Patient 4.2 and 4.3 are consanguineous. So are we missing any additional contributor?
So thank you, Alessandro and Lorenzo. The question is, when parents and patients raise questions about prognosis, about the risk, etc., and we have such heterogeneous phenotypes and imaging, it's very difficult to answer. Please consider that in 2000, the first variant in LMNA, 573, was considered absolutely pathogenic, namely a mutation, a disease-causing mutation. Vice versa, today, this variant is considered a VUS, a variant of uncertain significance. So it has been downgraded, and we could not now assign any causative role to this variant as a unique determinant of the observed phenotype in our patients. So if we consider past, present, and future, in the past we overestimated some of the variants, probably more, many variants in many genes associated with cardiomyopathies, and now we need to reclassify, and we need to take advantage of the long-term follow-up that has been fortunately performed in many centers. The present is that the identification of more than one variant per case in validated disease genes is increasing. For example, we have dystrophin and lamin. We have MYH7 and dystrophin. We have observed, obviously, is not so frequent, but it may occur. And in this case, it's very difficult sometimes to assign a role to each of the variants eventually, and if any. So the question is how to interpret genetic tests when phenotypes do not fully match the genotypes. We are obviously in the setting of cardiomyopathy, but we are in a setting of cardiomyopathies which may carry different, for example, arrhythmogenic risk, or different risk of heart failure or evolution to end-stage heart failure and need for transplantation. Another question is, should we still talk about variable penetrance or alternatively, when we have such important discrepancies in the phenotype, for example, the second program and the sister, the MYH7 variant of the second family is absolutely pathogenic, fully recognized since many, many years, so we have no doubt about that. But why this important difference in phenotypes between two SIBs who carry the same genotype? Or again, should we force variant interpretation under phenotypical umbrellas just because the identified variants typically pertain to one rather to another phenotype? In other words, should I force a lamin variant in DCM phenotype just because lamin typically is associated with DCM or not? And another question, are a priori a CMG criteria for variant interpretation enough to close a variant interpretation path? I think no. We need to progress. We need to progress with functional studies and with the segregation studies in family, in particular longitudinal segregation studies, which are probably those that have to support our future consideration of the risk in these diseases. In particular, I would underline the importance of investigating myocardial tissue when possible. And you may say, but these questions are just semantic, and I don't think so. These questions are related to precise clinical reasons. So for example, consider the impact of precise diagnosis on prognostic stratification, not only arrhythmogenic risk and sudden death, but evolution to end-stage heart failure. We have many patients here with end-stage heart failure waiting for transplantation. It's not easy to stratify the prognosis in these patients, and in particular when double genetic variants complicate the phenotype and the evolution. Sorry. And the second point, protect our patients from arrhythmogenic events. Is ICD implantation identically indicated in given patients because of the combination of clinical imaging and genetic data, or do we need to progress further and to search for additional information in order to provide best prescription? And finally, and not last, but the planning of procreative life is absolutely important, obviously. So we would appreciate your comments and contributions, and thank you very much.
Thank you very much for this interesting talk and presentations. Are there any questions from the audience? I don't see any questions in the chat. But you can unmute yourself. No.
There are no questions, so I think I can suggest a question or raise a question to the two speakers. For example, do you think, Alessandro, that the severity of the phenotype in our first proband may eventually justify the indication to a pacemaker implantation, even if the criteria, according to current guidelines, are not fulfilled?
In presence of VUS, only VUS, I don't think that there would be an indication, but I think that we should base our decision on the clinical. So if our patient has non-sustained ventricular tachycardia and has an history of symptomatic ventricular arrhythmias, as our proband said, I don't think that there would be doubt in the need of nice implantation.
Mm-hmm. And about diastolic dysfunction, Lorenzo, when you have to balance a variant that is typically associated with a phenotype in a variant which is typically vice versa associated with an hypertrophic phenotype, should we use the same criteria? Should we consider possible differences or make other considerations in these cases, or should we use our usual tools and rules?
Yeah, for sure, diastolic function should be an index in discriminating which phenotype will be predominant. Yeah, for sure. I think that it could be yes, a discriminant in this case.
Okay. But when dilated phenotypes also show restrictive pattern, is this a worse indicator, or this does not impact at all? Because it's not usually considered.
I think it is. I think it is a worsening indicator, and it should be considered in the final risk evaluation.
Okay. And that's it. These are questions that I have. I don't see questions from the audience, so I guess that.
Thank you.
We have one question in the chat from Gabriella, and she says, "I might have missed the slide, but are there LMNA variants in a particular protein domain, and are there any hotspots for missenses?"
Hotspot for missense, for sure, because as I told before, this variant, especially the first one, was repeatedly published as a pathogenic variant, and we also did it in the past. It was more than 15 years ago. We were fully convinced that that was a pathogenic variant, but actually we have observed the variant also in other complex cases, such as the one that you've shown today. Honestly speaking, we don't know how to interpret the role. In the second family, for example, the brother of our proband who carries only the lamin variant shows a myopathy phenotype, but not cardiac phenotype. So should we ignore or consider a potential role of this variant in the overall phenotype, especially in those family members who are carriers of both variants? It's very difficult when you have to close a report, a clinical report, and write and sign the diagnosis. In these cases, it's very difficult to take conclusion. I don't know if you have similar experiences.
I don't know if you can hear me. So I very recently started seeing families. I'm a geneticist, a clinical, and we have a few families with 2 mutations. And we've observed that in children, when they have a very precocious and severe phenotype. I do not have much experience with LMNA, and I don't know if the mutations are very different between myopathy and cardiomyopathy. I thought there was no real convincing genotype-phenotype correlation. It's what I'm learning still. So. But it's interesting, and because maybe I missed the part when you explained why the mutation was downgraded from pathogenic to VUS. It's because of the phenotype and the experience. So time is key.
It's not obviously up to us. We obviously follow the database criteria and we apply the CMG, but it was downgraded probably because of the frequency, because it's not so rare. And frequency now with thousands of genotypes obviously increased. And the second point is the segregation, especially in longitudinal follow-up was missing. Also in our experience, we have a big family with this variant. At the beginning, we were fully convinced that was the cause of the disease in a transplanted patient, a sudden death of his nephew. But after 20 years of follow-up, we are no longer convinced that that is a causative mutation. So we probably overestimated the weight of that variant. Today, we are really reconsidering all our LMNA mutation, but also many variants of other genes, which probably were overestimated at the beginning of our experience. No, I don't know if you have the same problem or...
Yes, I think that these considerations are also true for other genetic diseases. And because we now have better access to genetic tests and genomes, and we are always afraid of saying something wrong. It's true. Now when I see a family with very old genetic tests, I always think about recontacting the lab and updating the data. And I think it's important for clinicians to talk with the laboratory, the biologists, and to reconsider old cases because it's always evolving. And it might be interesting to think about genetic variants in cardiomyopathy as they do in oncogenetics as risk factors. And maybe it would be more true to say, well, this variation has a X% risk of giving the disease. But we are not, I think we're not there still, and they are not there still. So we need more data.
Yeah.
Can I ask one question?
Yes.
I thought about the families you counseled already maybe 20 years ago, and then maybe they were tested negatively on what you thought to be the pathogenic mutation. Do you recall those families? Maybe people are reassured because they were not carrier.
No.
But now maybe we're not sure if they are not at risk.
No, we at the baseline, one of the possible messages, I don't know what's the experience of other colleagues, but is if we rely only on baseline evaluation and segregation at the moment of the diagnosis may be not sufficient, because in big families, only the follow-up sometimes shows the occurrence of a cardiomyopathy that was not present at the time of the first evaluation of the family. And this is the obvious, not only for cardiomyopathies, but it's true also for many other diseases, and not last for cancer. Sometimes we miss the possibility of segregation, or we anticipate, or we run too fast on conclusions, when actually we should probably be more cautious in writing a definite evaluation of the pathogenicity of the variant. I think Gabriella is right. We need more time, and we need more and more larger series about these conditions, because finding two variants, one of which now is abuse and in the past was pathogenic, obviously is a little bit discomfort also for us. We also call back, and in any case, we revise the family clinically. The clinics is the support for the patient, and the segregation is the help for us to better understand the pathogenicity.
Yes. Yeah. Okay, thank you. Do we have any further questions? I don't think so. Anyone? Okay. Well, I think it's almost time as well.
Yeah.
So then, personally, I think it was we had a little disappointing number of participants, but hopefully many of the ERN network people will go back to the recording, which will be available soon on the website. So thank you very much, Professor Arbestini and your colleagues for this very nice presentation, and we are looking forward to the next webinar, probably next one, but we will inform you about that. Thank you.